All right. Good morning, everyone. So this is our third week of epidemiology. Hopefully today we can actually do some breakout groups and go through some exercise problems to talk about the material that we've been covering in the class up until this point. We'll do a really short review for some of the material that we've already gone over, just to make sure we're kind of on the same page. And just kind of a couple of updates for the class as well. I've been sending you the email updates twice a week. Those come on Mondays and Fridays. And if anything is pertinent in between there, I'll send more, but I try not to send you too many emails. I feel like that beginning and end of the week, at least for me, is kind of a good balance of like, here's how you're ending the week, here's how we're beginning it and what to expect coming up. If anybody needs any different communication than that, just let me know. I'm happy to modify or ensure that you're all getting the information that you need. So I think I met with almost all of you in student hours, and it was really great to kind of learn a little bit about who you are, what your interests are, what you plan to do after you graduate from CSUSM, and so on. I'm always happy to meet, chat about the class, chat about anything else that might come up to help you all not be successful this semester in this class and your other classes, but also to help you be successful beyond CSUSM as well. And so I know with many of you, we talked about things like internship opportunities and gaining experience to really help you figure out what you want to do beyond CSUSM. So if you still have questions about that or need help kind of navigating what internships look like and how to apply, where to apply, and so on, reach out to me. I'm happy to help there. And I often get internship opportunities that come across my email that I can forward along to if they're relevant to you. And there's a few of you that I've mentioned that I would do that, who have interest that I normally get internship offers in. And so that's one thing. If you haven't done your student hour yet, please contact me as soon as possible so that we can meet up and just kind of move forward from there. And then otherwise, your first homework is posted. That is due in about a week and a half or two. And then your first quiz is also posted. Technically, that's a goal due date of the end of this week. But same with the homework, same with the quiz, everything for before the midterm. So long as you submit it by the midterm, there's no need to ask for an extension, no questions asked. You can do it on your time and get it submitted before the midterm and you'll get full credit for it. But as I've said before, the main thing that I recommend is that you don't let the content pile up. You don't let the homework assignments pile up. You don't want to have 3 or 4 homework assignments and 4 quizzes to complete 2 days before the midterm exam, because you're really just not going to have a good time if that's what you're having to work on in 1 week. So try to keep on top of things. And if you find yourself falling behind, please reach out to me and let's strategize how to get you caught up and to move forward, staying on track with all of the course content. As I mentioned, I know the recorded lectures that I have on Cougar courses, they're a little bit more dense and there's more this last couple of weeks than there will be moving forward. And that is to ensure that I can get you all the basic material that we need to be successful throughout the rest of the semester. So the amount of content will kind of taper down a little bit as we move forward and we focus on specific topics within the field of epidemiology and applying some of what we're talking about in this first few weeks of the semester. But as always, never hesitate to reach out if you have any questions or anything. And then other than that, just do your best to keep on track with the recorded lectures and everything that I post. I post readings typically, and unless it says, make sure you read this and that's your journal article or something, any textbook reading and those types of things, those are optional. And I always put this as optional afterwards. And that is for people who like to read textbooks to get the information in a different way. And so I'll post those when appropriate. There's not going to always be textbook chapters that correspond to our lectures, but if there are, I'll post them for your reading pleasure if you would like to read, but you're not required to, you don't need to. You'll have everything you need to be successful in this class in the form of content that I have curated and created for you all. So before I move forward with starting out with a little bit of lecture, and today we're going to do a combo. I'm going to do some review. We're going to talk about the measures of mortality and morbidity and talk about some formulas that hopefully at least some of you have had the chance to watch those recorded lectures. And then I posted an exercise on Cougar Courses under this week's content. We're actually going to go into breakout rooms. I'm going to have you all work on some of those questions. We'll work through them together. I'll answer any questions you have. So this will be a really good opportunity to practice applying some of the formulas and some of the things that we're learning about in the class. And this will directly relate to your homework, where you will have to do very similar problems on your homework, and to the midterm exam, where you will also have to do very similar problems on the midterm. I will never give you a homework assignment or a midterm question where we haven't done some type of similar practice in the class, or where I haven't posted a recording that walks through exactly how to do the steps for that particular problem. And if you're ever confused by a question, I am never trying to be tricky. So if there's something where like, I'm not sure what he's asking, then please ask me, because it's not meant to be tricky. It just means that maybe I didn't word it the right way. So before I get started, any questions, concerns, feedback, or anything that you all need at this moment? Cool. All right. And as I've said, feel free to interrupt me anytime. I have the chat open. You can unmute yourself and say, whoa, stop, I have a question about that, or whatever it might be. I'll never be offended as long as you don't do so in a very way. And so I've successfully shared my screen. So this is a step up from last week. Awesome. And again, thank you all for bearing with me last week when we were having those technology issues. So, so shared it, but it was not in the right spot. So let me go back really quickly. Boom. And reshare. Okay, so today we're going to focus on measures of health and disease. But before we do that, we'll do a little bit of a review. But the objectives for today are to really be able to describe the role of surveillance and the process of surveillance in public health and why we do surveillance, to explain the differences between and be able to calculate different measures of health status, whether that's rates, ratios, or proportions, and some of the most common measures that we use to describe health in our population. And then really what we're talking about today is descriptive epidemiology. So if you remember back to lecture 1, we talked about the difference between descriptive and analytic epidemiology, where descriptive epidemiology is where we describe disease patterns in the population. The who is getting the disease, what is happening, where is it happening. So descriptive epidemiology is an important part of analyzing the health of the population. Then we can determine the how and the why, and that is the analytic epidemiology. And so this, what we're talking about in the beginning, is how do we describe patterns of disease and what measures do we use to examine the health of the population that can then be used to further examine why certain populations are more affected by different diseases, why they're emerging in the way that they are, and so on. So just to remind you, what is epidemiology? It's the study of the distribution and determinants of health-related states or events in human populations, and the application of that study to prevent and control health problems. So really today we're talking about distribution. And then as we move through the semester, we'll start to talk about determinants of disease when we talk about study design and how we conduct research in epidemiology to determine factors that are associated with adverse health outcomes. And then later on in the semester, we'll talk about methods that we use to prevent and control health conditions in the population. Last week, we also entered the field of social epidemiology, which is the branch of epidemiology that studies the social distribution and social determinants of health. So essentially that is, what are these factors that are external to the individual, such as societal and environmental conditions, that impact the health of communities and neighborhoods and individuals and populations? And so we really need to understand not just individual behaviors that impact people's health, but also these larger societal and environmental conditions that can impact behaviors and impact health as a whole. So we defined last week what social determinants of health are. And those are the circumstances that we are born in, grow up in, live in, work, and age in, and the systems that are put into place to deal with illness. And these circumstances are largely shaped by economics, social policies, and politics. So whether or not you recognize it, where many communities live, whether that is American Indian reservations or where people were able to purchase homes, those were all largely decided by political factors that decided what worth certain groups of people had and where they can live their lives, work, and what they can engage in our society. And this has all over hundreds of years had this trickle down effect to impact not just individual health, but the health of entire communities. And that has led to what we call health disparities. So those health disparities are differences in health status linked closely with social, economic, and environmental disadvantage that is as a result of some group that a person might be a member of or identify with, whether that is race, ethnicity, or by disability status, or by mental health status, or by where you live, some other factor that can impact a person's health overall. But one of the things that we talked about last week is that we often will describe health differences, and we'll do this a lot throughout this semester, by race ethnicity, where we will say people who are Black are more likely to die from COVID-19 than people who are white. People who are American Indian are more likely to have type 2 diabetes than people who are white. But I want us to think about when we're describing those health differences is that those disparities are not simply just a result of that membership in that particular group, whether that's race, ethnicity, or sex, or gender identity, or whatever that is, but as a result of the circumstances that are thrust upon people that are part of that group. And so a large part of, especially when we talk about differences by race, ethnicity, and health, that is not simply because there are genetic factors that predispose an American Indian to be more likely to develop type 2 diabetes. Rather, the reason that American Indians have a higher prevalence of type 2 diabetes is because the social and environmental conditions that were forced upon them to make them live in reservations that were not their traditional territory. And what has happened over many years, especially in American Indian communities, is the fact that their water rights have been stripped for them. So water is a very precious commodity, right? We can't live without water. We can't grow food without water. We can't do anything in our daily lives without water. Most American Indian reservations and traditional territory was in areas where there were good water sources because they were hunter-gatherer communities, they were sustenance farmers, they were self-sufficient. When they were moved to reservations, those were often places where there weren't good water sources because the government wanted that water for their own purposes. So that meant that actually when American Indian communities were moved to reservations, they were actually given food commodities by the US government. What those food commodities were basically boxes of product to sustain the communities. They didn't contain fruits and vegetables. What they contained was flour, lard, processed foods, canned goods, things that were easily stored and maintained over long periods of time. These were not foods that were traditionally eaten by American Indian communities. So as a result of those foods being provided, their water rights being taken away, them not being able to practice farming and their normal hunter-gathering practices, that led to a decrease in the amount of activity that they were engaging in as a result of their daily lives, and an increase in the consumption of unhealthy foods that resulted in higher rates of overweight and obesity, type 2 diabetes, cardiovascular disease, and so on. So when we look at those health differences by racial ethnic group and we say American Indians have a higher rate of type 2 diabetes, it is not because they're genetically predisposed to it, despite the fact that some researchers have tried to find genetic factors that make them more likely to develop type 2 diabetes. It is the fact that they have been placed into the environmental and social circumstances that has changed their behaviors and led to them having a higher prevalence of these diseases where they didn't exist in the first place. So this is kind of some of the framing that I want you all to think about when you're thinking about health differences and health disparities. And so part of that is as a result of racism and discrimination that many people face in this country. And when we think specifically about racism and discrimination, present day hate, whether that is racism, sexism, homophobia, religious persecution, or many other forms of discrimination, has been built on a long history of racially and unequally distributed resources and ideas that shape the view of ourselves and others. It's really this hierarchical system that we live in that shapes many of our communities and our behaviors, and the current institutions built to keep those practices in place. And so one of the large things that I want you to think about and what we defined last week was institutional racism. And institutional racism is this idea that there are institutions, environments, policies that are built to disadvantage certain groups of people. And we talked about specifically with the practice of redlining last week in our live session. And redlining, if you remember, was essentially the practice where there were certain, so if someone was Black, they were not allowed to get a mortgage in certain areas of different cities because they were deemed to have less worth, regardless of their income, regardless of their job, regardless of any other factors of that family or that community or that individual, that if this color of someone's skin was, there was a clause in those mortgages that said solely based on the color of a person's skin can be denied a mortgage. And there were certain areas of the cities that were deemed to be higher class neighborhoods where people were kept out of. And so that practice was called redlining. And what we've seen today is those practices of redlining have actually directly impacted the health of those communities and the individuals that live in those communities. So if we think about neighborhoods that were redlined where people who are Black were able to get mortgages and purchase homes and develop communities, those neighborhoods are less likely to have parks. They're more likely to have tall buildings and unsafe structures. Those neighborhoods are also associated with things like higher rates of asthma due to the types of industries being closer to factories and other things that are impacting the health of the children growing up in those neighborhoods. They're more likely to be hotter because they have less trees and parks. And that increase in temperature is actually related to a number of potential health outcomes. And so we have seen directly the impact that these policies of redlining from the 1930s have had today on communities that are living in those regions. And so these are the types of things that in order to address health disparities and to move forward, we need to be able to address these larger societal and political factors that are impacting the health of communities. And so to kind of end up this review, one of the things that I'd like for you to take from this class, and something that we'll continue to talk about throughout the semester, is that when we talk about health, oftentimes in our society, we talk about health as an individual problem. So if someone has type 2 diabetes, that's often talked about as, well, they didn't exercise and they ate poorly, so that led to them having type 2 diabetes. But what I want us to do is frame health as something not just as an individual problem, but as a larger societal problem that has created a structure that has not allowed certain people in our populations to engage in behaviors to affect their health in the long term. And so health starts long before illness, long before we engage in any behaviors. Our health has been impacted by things that our families and our communities have been exposed to, by things that are in our neighborhoods as a result of these policies and so on. It starts in homes, in schools, in our jobs. And so we need to think about how all of those things are impacting our health. Our opportunity also starts long before we're seeking any kind of medical care. So if someone is having health issues, that likely started years before they're actually going to a doctor that they're seeing. And they may not have had, say, type 2 diabetes at that moment, but there were things that were happening that were leading to them being pre-diabetic or being insulin resistant or so on, that led to them eventually having to seek medical care. And all Americans should have, and everywhere, and really globally, should have the opportunity to make choices to allow them to live a long, healthy life, regardless of their income, their education, or their racial ethnic background. And this is something that a lot of policies that we have, that is policies surrounding who has health insurance, who can access healthcare, where you can go to school, or many other things, are impacting our ability to make those everyday choices. Because if I don't have health insurance, for example, and I am exposed to COVID-19, and I need to go to put food on my family's table tomorrow, I may go and get tested for COVID-19 because that food and that is more important to me than going and getting a test. And so these are all things that we need to think about, especially with things like the spread of COVID-19 and so on. And of course, importantly, your neighborhood or job shouldn't be hazardous to your health. But unfortunately, there are many neighborhoods, there are many jobs that are hazardous to people's health, and we don't always have the right protections in place to minimize those risks to people's health. So for example, living closer to a freeway. There's actually a lot of research that shows that living closer to a freeway is hazardous to health. But what do you see happening right now in San Diego County? Despite the years of research that shows that closer to homes, the closer that apartments are to freeways, the more likely to expose dust and other particles and smog and things from the cars, that's going to exacerbate health issues. But what do you see happening? We're building large communities that are literally, like, they may as well just be over the freeway at some point. Like, if you've ever driven on the 15 freeway by Mira Mesa, which is where I live, there's a huge complex of almost 2,000 apartments that's been being built for about the past 8 years. And somebody from their balcony could throw a quarter out and probably hit a car. It's so close. If you think about the amount of dust and smog and things that are those people are exposed to, that's going to potentially impact their long-term health, whether that is their children's asthma rates or other potential things throughout their lives. So we need to think about where we live and build and how we prioritize health in neighborhoods and policies and so on.
Yeah, I actually saw something like similar to that. It was with jets and airplanes and stuff though. Like the stuff that you're getting from that, it like actually super heavily impacted health rates in area and people that were living like really close to those airports and stuff. It's kind of
Yeah.
trippy.
Yeah, so like right around the airport area or under the low flight path as planes are taking off, all of those things. And that's often we don't always think about those things, because more importantly, it's often about economics and how much money someone can make versus protecting the health of the communities that people are actually living in. Yeah, apartment literally under the 78 freeway, stadium demolition. So there are policies in place. So for something like the stadium demolition for Qualcomm that's happening right now, the reason that wasn't actually imploded using bombs is because of health standards in terms of being able to protect or to prevent and minimize particulate matter in the air as a result of that explosion. And there were building materials that were used to build Qualcomm, like asbestos and other things, because it's so old, that could become potentially hazardous to the health to the communities that surround them, and actually really all of San Diego County based on wind patterns and stuff. So they're actually tearing it down like piece by piece using tractors and stuff to prevent the amount of particulate matter that goes up. And there's levels that are monitored every day. So as they're tearing down Qualcomm, there actually has to be somebody with a hose spraying down water the entire time to ensure that it keeps the levels of dust down and prevents that from spreading to other areas surrounding Qualcomm and so on. So there are actually specific policies that are meant to help minimize that. How they're tracked and followed and stuff, we don't, unfortunately, it's not always equitable in different areas. But that is something that luckily does happen in some areas. Any other questions, or what other questions you have about kind of that review and that section that was really from the last couple of weeks? Cool. All right, so now we're going to kind of jump into some of the content that was in the recorded lectures from this particular week. And really this week, we're talking about measures of morbidity and mortality, and we'll talk about some of those different measures. I will say, and this is always a caveat I give for this particular lecture, whether it's the recorded material or some of the stuff we're going to go through today, it's dry. It's lots of formulas. There's really no way to like make these formulas super exciting unless I did a, sing and a dance in the background, and you don't want to hear me sing, trust me. So we're going to talk a little bit about surveillance and the importance of surveillance, and then how we actually do different measures of morbidity and mortality to track health in our population. And again, this is all descriptive epidemiology. So public health surveillance is the ongoing systematic collection, analysis, and interpretation of health-related data that is essential for us to plan and implement and evaluate public health programs. The surveillance is really used to track disease in the population so that we know what's going on, where disease is happening, so descriptive epidemiology, where outbreaks are happening, where we see differences in health status, and so on, to develop programs to prevent and control health outcomes in the population. So the goal is really to provide information that can be used by public health systems, whether that's county health departments or state health departments or the Centers for Disease Control and Prevention or the World Health Organization, which are some of the large organizations that deal with public health, to develop policies and planning and programs to help the health of the population as a whole. So these are all the uses of public health surveillance, as I mentioned. So identify people with disease, detect epidemics. And so if you remember from week one, an epidemic is when we see the rate of disease in a given area higher than what we would expect it to be. So an example of that could be if we normally see 1,000 cases of chlamydia in San Diego County every year, and then last year we saw 5,000 cases of chlamydia in San Diego County, that would be considered an epidemic of chlamydia. Or probably a more relevant example is after Coachella, which was canceled again this year. After Coachella, there's actually usually an epidemic of sexually transmitted infections where they see a huge increase in the number of people going and getting tested and diagnosed with chlamydia, gonorrhea, and syphilis because of the behaviors that people are engaging in while they're at Coachella. And so there's actually large reports specifically about Coachella and other large music festivals that are similar, where they see in the regions where people are traveling from to go to the music festival, that they see an increase in the spike of number of sexually transmitted infections. So use protection, get tested regularly, engage in sexual behavior, but do so as safely as you can, there's a lot of ways that we can prevent the sexually transmitted infections. Other uses of public health surveillance is to estimate the scope of a health problem. So as we track disease, if we see it continue to increase, then we know that the problem is becoming larger, the burden is becoming larger, the risk is becoming larger. So we can think about the environment we're in right now with COVID-19. There has been ongoing active surveillance for COVID-19 over the last year or so to manage and determine the impact of COVID-19 on their populations. And that data has been used to not only characterize trends in the disease overall, but also to help develop policies that are put in place to mitigate the spread of disease. And that's also been used to help develop hypotheses and stimulate research. And so one of the things that we'll kind of talk about throughout this semester is that public health surveillance and that general tracking of disease is extremely important. And that is used to determine causes of disease and how we can prevent it. But the scientific process as a whole, and what we've seen happening with particularly the COVID-19 pandemic, is there has been a ton, and this happens with all diseases, but particularly bad with COVID-19, a ton of misinformation and a ton of anti-science and misunderstanding of how science works. And that is something that I hope from this class, as we think about how we collect and use data in public health and in epidemiology, that you all will become people who your friends and your family can go to ask questions about things that they see in the media, whether it's about COVID-19 or other diseases. Because what we've seen, for example, early on in the pandemic, their recommendation to use masks was they didn't recommend using masks because we didn't understand how COVID-19 was spread. And it wasn't until we started to gather more data about the actual spread of COVID-19 that that recommendation was changed to say, based on this new data that we have gathered, we now recommend masks as a potential protective measure to prevent the spread of COVID-19. That was only after that data was collected. And an important part of science and of understanding research is also understanding the fact that recommendations to protect health and to prevent the spread of disease may change based on new data and new information that we collect. And that is part of the scientific process in ensuring that we're using the best evidence possible to disseminate information to the public and to protect their health. That process is not always well understood, and that often when recommendations change, the initial reaction from the public is, well, you got it wrong, and you told me not to do this before. Why should I believe you now? And it's not necessarily, and there are times where it was just wrong, right? So there were just recommendations that were wrong because they're based on bad science. But in many cases, those recommendations are based on the best science that we have available at that time, and they are continually evolving as we develop new research and new understandings of disease spread and so on. So that's something that we'll talk about throughout this semester too, and how even data from surveillance can be used to understand how those recommendations change. So there's two main types of surveillance. There's passive surveillance and active surveillance. Passive surveillance is one where diseases are reported by healthcare providers, and it's simple and inexpensive. But so basically what that means is there are actually a large number of what we call reportable diseases in California and in the United States as a whole. The what diseases are reportable actually varies from state to state. But for example, HIV is a reportable disease. So if someone goes to Planned Parenthood or their primary care physician or some other place to get tested for HIV, and that test is positive, that healthcare provider has to report that positive test up to the County of San Diego, who then has to report it to the California Department of Public Health, who then reports it to the Centers for Disease Control and Prevention. That is a passive process in that it is initiated by the healthcare provider themselves, and there is no one at the state, at the county, or at the CDC who is actively looking for those cases of disease. And how often that has to be reported is dictated by the disease. So for example, new cases of HIV have to be reported on a weekly basis by local healthcare agencies. Other diseases might only have to be reported on a monthly basis, but in a passive manner. So you can imagine that this can also lead to incomplete data because not everyone's going to report data in the same way. The other process is active surveillance, where then healthcare agencies like the Centers for Disease Control and Prevention or the California Department of Public Health are contacting health providers to gather disease reports. This ensures more complete reporting and ensures that we're fully tracking the scope of disease in the population. So for example, with COVID-19, we have active surveillance going on so we can fully understand the scope of the pandemic in different regions to make recommendations for mask wearing, shutdowns, and whatever that might be. And so that process of active surveillance is more complete, but it's also more time consuming because you actually have to have people who are contacting health providers and others to gather that information. So then that leads us to what type of information are they actually tracking? And that is our measures of disease frequency. These measures of disease frequency are used to describe and compare disease outcomes in different populations and behaviors that people are engaging in. And this helps provide information about what's going on in the population. In order to calculate a measure of disease frequency, we need to have these 5 components. We have to first have a case definition, or what is disease? So essentially, a case definition is actually the most important part of a measure of disease and health, because it's a criteria that we use to say, if you have these symptoms, or if this virus is detected in your blood, or these antibodies are detected, we are going to say you have this particular disease. So that might be for something like COVID-19, where the case definition is that they get a test and the antibodies for COVID-19 are detected, or that they get another test and actual viral pieces are detected in their blood. The case definition varies from disease to disease, and case definitions can also change as we gather new information. I'll show you a quick example in a moment. To also calculate measures of disease frequency, we need to know how many people are affected, what the population being examined. So who are we measuring this for? Is it San Diego County? Is it the city of San Diego? Is it just students at CSUSM? We need to know when the disease happened. Is it a new case or a case that someone's had for 10 years? And we need to know the time period that it happened. Did it happen in 2019, 2017, 2020, or so on? Because that all gives us the correct information to compare and describe disease against each other in different areas. So just quickly, and I'm not going to go through all of this, but if we look at AIDS, which is caused by HIV, this is all of the different case definitions. And this isn't actually all of them. There's been smaller additions that have happened in between. But starting in 1982, this is what a case definition of someone having AIDS was. And then now you move to current, that case definition is actually different for AIDS than it was in 1982. So that means that if we actually applied that case definition that is our current case definition to 1982, that would actually change the number of people who meet the case definition for AIDS. And that would actually change what that surveillance numbers looks like. So these case definitions and how we're defining disease are extremely important, because when someone's evaluating how disease patterns have changed, we need to ensure that it hasn't changed just as a result of how we've defined that disease. So for example, likely the number of people who meet the criteria for AIDS has decreased globally as a result of us changing the criteria and actually lowering we're making it more difficult for someone to be diagnosed with AIDS. And so that has changed how we've surveilled the disease and what it looks like. So when we look at from 1982 to 2020, the number of people with AIDS in the United States, if we don't see it increasing, or if we see a change in the pattern of disease, what we also need to examine is how has that definition changed that has led to that potential change in the pattern of disease as well. So there are many different measures of disease patterns that we would use. And I mentioned before that you have all of the formulas. They are on Cougar courses, but there are measures of mortality, which are measures of death. And there are measures of morbidity, which are morbidity is some health condition that you might have. And so we will learn how to calculate both measures of morbidity and mortality in this class. As I mentioned, here's just a screenshot of the formulas that are on Google Courses. You have access to this for all of your exams, for all of your homeworks. I recommend if you have a printer, print it out and have it available while you're going through things. If not, at least just have it saved somewhere on your computer so you can easily open it up and use it while you're going through calculations and you're not going back to PowerPoint slides or something. So let's first start talking about what rates are. So all of what we're going to talk about are rates or proportions. And you've all probably seen rates and proportions at some point throughout your education, starting in your math classes, starting in your statistics classes. We're not going to do full-on statistics in this class. I purposely leave it out because that is the next step of learning methods in epidemiology that is we don't often introduce in an intro class. But a rate in epidemiology is what we use to compare disease patterns in populations. Rates contain the disease frequency, so how many people have the disease, the size of the population, so who is it that we're actually calculating this rate for, so that's the numerator and your denominator, and the time period for which the event is occurring. So in a specific year, in a specific month, in a specific week, or so on, and you define what that time period is. So an example might be the number of women who died of breast cancer in 2016 over the total number of women living in 2016. What I mentioned before when we're talking about these rates, one of the most important things is that you are clearly defining your unit size of your population is, or your denominator. So if I am trying to calculate the rate of mortality from breast cancer among women, that means that my denominator or unit size of my population should only include women and not also men in the population. And so we need to be careful about what number plugging into the formulas. The math itself, really simple, division, multiplication, subtraction, but the figuring out your denominator, especially your unit size of your population, is where most students usually struggle. And this becomes important because if I were to include both men and women, that would drastically change that rate of mortality from breast cancer. Or if I don't include a time period of 2016, that will make this measure really hard to interpret. So if I don't say during 2016, within, does that mean that this is the rate of breast cancer mortality in a person's lifetime, or last year, or over a 5-year period? And those are all very different measures. If the rate of breast cancer mortality is 25 per 1,000 throughout an entire lifetime, that's maybe not really high. But if it's 25 per 1,000 in a given year, that number would seem much more severe. And so we need to be able to define when and how we're doing that calculation.
May I ask why breast cancer is more prevalent in women than it is in men? Do you happen to know that?
I don't know. Well, so I know there are some different genetic factors, and there are some genes that, and there are some actual genes that impact breast cancer, but they actually vary by ancestry and lineage. But I don't know the exact, I don't know if anyone else does. I don't know much about kind of, so men can get breast cancer at much lower rates. And I think it might just be a result of the amount of breast tissue. And estrogen as well. So there is research that shows that estrogen increases risk for breast cancer. So there's different hormonal factors and genetic factors that are different in men and women that lead to different rates of different cancers and so on, which is why it's also important to describe. Yeah, so there are different types of rates. There are crude rates, there are specific rates, and there are adjusted rates. We are not going to do adjusted rates in this class because they are complicated and I don't want to have you have to work through those. So you don't have to worry about adjusted rates, but know that they are actually another important measure in epidemiology. So I'm going to quickly go through what these formulas are. Like I said, quickly, because you're going to actually do some sample problems in just a moment. Mortality. This is one of the major measures of disease frequency in the population. And it's really a measure of the overall health of the population as a whole. As the mortality rate increases, we're potentially thinking that the population is less healthy than when we have a lower mortality rate. This information where we get mortality information is from death certificates. And this is required by law that the cause of death is indicated on a death certificate. And that is used to calculate not only the crude mortality rate or the crude death rate, but also specific mortality rates from different causes. So simple formula, crude death rate equals number of deaths in a time period over the number of people at risk of dying, which is every single person in the population, because we haven't found out any formula for immortality yet. And so crude death rate is calculated out of the entire population. One thing I want you to think about for the crude death rate is that it can be limited. So if we compare, say, for example, San Diego to Palm Springs, California, or California to Florida, who do you think has a higher crude death rate, California or Florida?
Florida, because they have a higher elderly.
Yeah, so Florida, because they have a higher elderly population, because a large number of people retire in Florida. So you can't compare crude death rate to crude death rate in different populations, because those may be driven by the makeup of that population, by age distribution, sex distribution, or other factors that lead to one population having a higher rate of disease. And that's where those age adjusted and adjusted death rates come into play to allow us to do more direct comparison. But we're not going to really go through those in this class. And then there's specific rates. They're very similar. There's cause-specific rate and there's age-specific rate. A cause-specific rate is just a death rate from a particular type. So it could be COVID-19 cause-specific death rate over the total population at risk in time period, or number of heart attack deaths over the total population at risk for heart attack, which again is the entire population. Could also do an age-specific death rate, where you're looking at the rate of death in a specific age group. So say number of deaths among 15 or 5 to 14-year-olds over the total number of 5 to 14-year-olds. And this is where this can become tricky, where you want to look at specifically your denominator is only going to include 5 to 14-year-olds if you're looking at an age-specific death rate for 5 to 14-year-olds. So if there's a problem that you have that asks specifically for a particular age group or a particular disease, ensure that you're selecting your right age group. And then infant mortality is another measure that we use to look at population health as a whole. And this is the number of deaths that die under deaths for infants under 1 year of age over the total number of live births in that time period. And this is a measure of overall population health that we often use to compare countries to each other. And I have a little bit about this in the recorded lecture, and there's a figure that shows that unfortunately the US, in terms of infant mortality, compared to other developed countries, we don't do very well in terms of infant mortality. And actually our rate of infant mortality is almost double the average of most other countries that are of similar development. So that's a problem, and that's largely as a result of us having differences in infant mortality in different racial groups as a result of racism and discrimination. And then the other two measures of mortality are the case fatality rate, which is the proportion of people who die from a disease. So it's the number of people, a number of deaths among people with that disease over the number of persons with the disease. It's really actually a ratio and not a rate, but it could be, for example, the proportionate mortality of cancer. Oops, sorry. So it could be a proportionate mortality of cancer. So it's the number of people with cancer. So number of people who die from cancer over all the people with cancer would be the case fatality rate for cancer, or the number of people who die from breast cancer over everyone who has breast cancer. The case fatality rate is actually a measure of severity of disease. So if you look at that proportion, and it's 90% of people with a particular cancer die from that cancer, that tells you that that disease is fairly severe. Whereas if the case fatality rate is only 5% or 2%, and only 2% of people from that disease die, then that would tell you that it's a little bit less severe. And we'll talk next week specifically about the case fatality rate for COVID-19, because there's a lot of media coverage surrounding it's only 1% of people with COVID-19 die, and a lot of people try to use that as justification for us overhyping the pandemic. But we'll actually talk about what that means and how that's oftentimes misleading, especially when we look at the different demographics who are dying from COVID-19, and also really what 1% of the population means. So if you think about, 1% of 1,000 people, or 1% of 1,000,000 people, or of 300 million people, that's not a small number of deaths. And so really, in my mind, one death is too many. And if we're thinking, well, we can sacrifice, 1% of our population, and that means we don't have to wear masks and these things, we'll talk about the kind of the implications and what that means as a whole next week. And then the last one is proportionate mortality. And that is the proportion of all deaths due to a specific cause. So that would be the number of deaths from a specific cause over the total number of deaths. So this could be proportionate number of deaths in our population from suicide over all deaths in our population. So we usually use proportionate mortality to look at the top 10 causes of death in the population. So you've probably all seen those leading causes of death graphs, where leading causes of death in the US are things like diabetes, heart disease, stroke, suicide, accidents, and many other often chronic preventable diseases, actually. And so that's another measure that we use to kind of track how disease is spreading. So what I'd like to do now, for probably actually about the remainder of the class, is to get into, we'll come back about 10 minutes before we end at least, and I'll cover a couple of things. Well, actually, we'll come back about 15 minutes before, and I'll go through some of the problems. So I'm going to put you into breakout rooms randomly. I can't put you into rooms with people that you know, because that would take me way too much time to try to go through the list of 35 of you. There is an exercise on Cougar Courses that I mentioned earlier. It's exercise 1 under this week's material. And it has some sample problems where you have to, so what I want you to do is go through part A together. Calculating crude mortality rate, calculating proportionate mortality, calculating case fatality, and so on. Work through those, make sure you have the formula sheet open, make sure you're pulling the right numerators and denominators. So I want you to go through those as a group. I'll give you about 15, 20 minutes, and then we'll come back and we'll go through some of those measures together as well, to ensure that you're all kind of coming up with the right answers and understanding what it is that you need to do these calculations and what they mean. So before I do that, you're going to be put into breakout rooms of 4 people per room. So what questions do you have before I put you into those? Cool. So as I put you into them, it'll pop up on your screen. If you've never been, hopefully you've all been into breaks before, it'll pop up on your screen to just join that room. If your group has a particular question, you can come back out to the main room, and I can jump into your room to answer any questions that you have. If you come out to the main room and I'm not there, that means I'm in with another group, and I'll be back out in a couple of minutes and can come help your particular group. So we'll plan to come back at about 45 after to give us some time to go through some additional questions. It may not be enough time for you to go through all of the problems, but that's okay. You have this for home, and we'll go through some of this next week as well. So I'm going to open up all the rooms now and go ahead and work in your groups, and let me know if you have any questions. So I'm actually going to unpause the recording. You didn't need a recording of 20 minutes of me just standing here waiting for you all to come back from the breakout rooms. And so let me share the screen, and I'm going to attempt to do this on my iPad because that allows me to actually walk through some of the problems. But sometimes it gives me issues. So if not, I'll just pull up the slides again on my laptop. So give me 1 second.
So next class, are we going to do part B together?
So you could start part B on your own if you would like. There is a recording specifically how to go through it. I'll introduce it in just a moment if I have some time, but then we'll go through it together next class as well.
Okay. And this we don't turn in, correct?
You do not, no. This is all for your own knowledge. And I will also post all of the answers to all of these exercises because we'll have either exercises with calculations or other problems throughout the semester. They're all for helping you all practice and go through things. You don't have to turn any of them in for credit. Okay, so first problem on the exercise says, what is the crude mortality rate in the US in 2010? And the one thing I didn't really go over, but I wanted to see if anyone had watched the recorded lectures or could figure it out, is state per 100,000 persons. Show your work. So what is the formula for crude mortality? So it's the number of deaths in time over total pop in time period. Sorry, I should probably try to write a little bit nicer. It's a little hard on my iPad. So then what two numbers? So what were the total number of deaths in 2010? Oh, yep.
So on the worksheet, is that the proportionate mortality ratio?
It is not. So that on the worksheet, it's just going to be the rate. So this is just a crude rate. And so the mortality rate is just the crude mortality rate. So it's going to be the fourth formula.
The rate equals times multiplier?
Yep.
Okay, thank you.
You're welcome. So I don't give the specific number of deaths in the over total population because there's many different rates. So this is the, so that you can add that in on your own if you want, but yeah, so it's the rate one. So what's the total number of deaths?
Is it the 2,368,435?
2,368,435. And what's my total population?
Is it the 308,845,538?
Yep. So
and then are you
then
going to multiply that by 100,000?
Exactly. So first you divide those two numbers by each other, and that should give you 0.007667. So that's a really small number. That number is not extremely interpretable, right? So that's where that state per 100,000 persons comes into play, and that is in the formula, that multiplier. So I would multiply that by 100,000. And that is going to give me what Rosalind put in the chat, which is 766.87, or you can do just 767. I'm not a really big stickler on rounding. So long as your answer is very close to whatever it is the correct answer. So if you would put 500, obviously that's incorrect. But if you put 766.87 per 100,000 or 767 per 100,000. So now what that multiplier is in this case is that tells me if I had 100,000 people, how many would I expect to die in 2010? So we would expect that about 767 people per every 100,000 people in the population died in 2010. So it gives me a little bit more comparison and information about out of how many people am I doing this calculation. So you're always going to have some multiplier. And for the purpose of the problems that I give you, I will always give you what that multiplier is. So I might say state per 1,000 persons or 10,000 persons. It will change depending on the disease, depending on what you're calculating and so on. If you have a really, really rare disease, we might calculate it out of 1,000 persons in the population. Or if you have a really common disease, we might calculate it out of 100,000 persons. So it kind of varies from disease to disease. And that allows us to do some comparison across populations, keeping in mind the limitations of our crude mortality. Any questions about this particular calculation?
When we give you the answers, do you want us to write per 100,000, or can we just do like 766.9?
So you would do, so actually for the answers, and I should put that here too, you would give me 766.9 per 100,000 in 2010. So you always want to give me the answer, the multiplier, and the year or the time period, because all three of those pieces of information are needed to be able to appropriately interpret what that means. Because if I don't have the time period, is that in 2015, in 2011, or in some other year? If I don't have that per 100,000, is that 766.9 per 1,000, per 10,000, per 100,000? And those are all very different answers. So I want you to get in the habit of always giving me all three pieces of information: the answer, the multiplier that you're given, and then the year or the time period that you're doing the calculation for. Cool. So let's move on to the next one. What is the proportionate mortality of Alzheimer's to all deaths in 2014? And you're going to express this as a percent. So what is my proportionate mortality? So if you remember, that is the number of deaths due to a specific cause over total number of deaths. So I'm going to just abbreviate it as PM, number of deaths from Alzheimer's over all deaths in 2014. So then I'm going to go, and so how many deaths were there in 2014 due to Alzheimer's?
83,541.
And then what is my denominator here?
2,726,418.
So, and this is a common mistake I'll see on problems like this, is you're looking at that total deaths, which is this first column from this first table in 2014. And so remember that your formula is of all deaths, not of your mid-year population, which is what's given to the right of that. And I'll commonly see people calculate proportionate mortality using that mid-year population as opposed to the total number of deaths. So just make sure, sometimes it's just a simple transcribing error where you accidentally grab the wrong number from the table. So be careful about what numbers you're writing down. Other times it's that you just mistake what you're calculating and choose the total population versus the number of deaths or some other thing. So then that gives me my proportionate mortality of what? I don't have it calculated out. Who calculated it?
I multiplied it by 100, so it's already in percentage, but I got 3.1%.
Yeah, so if you just do the math, 0.0306, and then multiply that by 100, or you can do it earlier, equals 3.1%. So what this tells me is that 3.1% of the deaths in 2014 were due to Alzheimer's. So it just tells me overall what proportion of deaths were due to that specific disease in that year. So I don't have enough room to write it out here, but ideally in an answer, I'd want you to write out 3.1% of deaths in 2014 were due to Alzheimer's. So again, that gives me all of those different components of this calculation. So I know exactly what that specific cause was. I know the year, and I know out of what. And in this case, it's out of all deaths. Any questions about that one? So next one, cancer mortality rate. So what type of rate is this? This is a specific rate. So we're calculating the mortality specifically for cancer in 2014. So I'm just going to abbreviate it again as CM. So cancer mortality rate is going to be the number of deaths from cancer in 2014 over pop in 2014. So my cancer mortality rate is going to be what?
Uh, 21,702.4.
So I'm going to do 591,699, which is my number of deaths due to cancer in 2014 over my population in 2014.
Why would it be population and not the total deaths?
So we're calculating a mortality rate and not the actual proportion. So if I did it over the total number of deaths, that would be my proportionate mortality from cancer in 2014. So that's a different calculation. That's similar to what we did in the previous problem for Alzheimer's, where we calculated the proportionate mortality of Alzheimer's. So I could calculate proportionate mortality of cancer in 2014 and do it over the total number of deaths, but that gives me a different interpretation and a different number than if I am calculating my cause-specific rate from cancer in 2014, which is out of my total population.
So is this one more like A?
This is pretty much the same thing as A, but we're specifically looking only at cancer deaths. Yeah. So this is, again, where that denominator becomes really important in terms of what we're calculating. And we want to make sure that we are using the right denominator for every single calculation. Cause specific takes the total population and case specific number of the disease. So the cause specific rate takes the total population, yes. So total population overall and the specific number of deaths from that particular disease. So essentially what this will tell us is what is the rate of death from cancer in the entire population. So we should see that this rate would be, and we can do that calculation. So that would give us 0.001855. And then I say per 100,000 again. So that gives us 185.51 per 100,000 in 2014. And so my interpretation of this would be in 2014, the cancer mortality rate was 185.51 per 100,000 people in the population. And we should see when we compare this to that first calculation, which was the overall mortality rate, that this number is much lower, right? Because this is only, cancer deaths only account for a certain proportion of all deaths in the population as a whole. And so that gives us a little bit different, okay, what is the impact of cancer when we're looking at mortality overall in our population? So it gives us a different way of looking at specifically for all cancers, what impact do they have in mortality in our population? Does that make sense? Is that helpful?
Yeah, definitely.
So then we'll think the last one, and then there's one kind of more multiple choice or like a more question. So if 1 million persons had a diagnosed case of cancer in 2014, what is the case fatality rate in 2014? So the case fatality rate is given on your formulas. Case fatality equals number of deaths from that cause over total number of people with that particular disease. So in this particular case, in 2014, what this would tell us, I'm just going to do CF equals, if it's we're looking at cancer case fatality rate, that would mean that we have 591,699 deaths from cancer. So that's the total number of deaths from that specific cause in 2014 over the total number of cases of cancer in 2014. And that's going to be that 1 million that I give you. So now I would just divide those two numbers. That just gives me 59.1%. I say express it as a percent. So what that tells me is that of all of the people who had cancer in 2014, 59.1% died from cancer, from that particular disease. So this tells me about the actual severity of the disease as a whole. So if I'm so I guess that relates to the next question. If a patient is diagnosed with cancer, they might want to know their risk of dying. What would be the most appropriate measure to tell them? Their proportion of mortality, their cancer mortality rate, or the case fatality rate for cancer to provide to the patient. So what one would be the most appropriate to provide?
Case fatality.
Yeah. So it'd be the case fatality rate, because that actually tells us if you have cancer, and you could actually separate this out by type of cancer, basically how many people die from that particular diagnosis. So if you have something 50, 60, 70, 80%, that tells you the disease is likely fairly severe and that your chance of survival is much lower. Whereas if the case fatality rate is, as I said earlier, 1, 2, 3, 4, 5% or 20%, that's a much lower severity. And so that allows the patient to evaluate kind of what their diagnosis means in terms of their overall health and their long-term survivability. This is just one measure we use for that. There's many other things we look at. So if we're thinking about cancer, these case fatality rates are going to depend on the stage of cancer and the type of cancer and many other things as a whole. This is just a general kind of calculation that can be used to examine the overall severity of the disease in the population. We can contrast that with something like proportionate mortality, which is just what proportion of deaths are due to that particular cause. So that tells us a little bit more about the burden of disease. So for example, if cancer accounts for 50% of deaths in our population, we have a really high burden of cancer as a whole. So we might want to allocate more resources for research, for treatment and services for people who are diagnosed with cancer to minimize the burden of cancer as a whole in the population. And then our overall case fatality rate, that just tells us what's the rate of death in the entire population for that particular disease. That doesn't tell us anything about an individual's health or what's going on. It tells us more in our population as a whole what is going on. So any questions that you have about those particular calculations and applying measures of mortality and what they mean, how you calculate them, the multiplier, or whatever else might come up. Cool. So next week, we'll go over at the beginning of the class, incidence and prevalence, which are our measures of morbidity that we use really commonly in epidemiology, with our prevalence being the number of existing cases of disease and our incidence being the number of new cases or risk of disease. So these are our two most commonly used measures and calculations in the field of epidemiology, and we'll use them throughout the semester. But you'll see kind of what goes into calculating prevalence and incidence. And we'll also introduce this new concept, and you'll see this on your homework assignment, which is something that often, it's a brand new concept for most students, but it's this idea of what we call person time. So there is a recording specifically on person time that I recommend that you watch before our next live session, because it'll help walk you through what person time is. And it's essentially the amount of time that a person is at risk for a disease. And that at risk is extremely important for our calculations for incidence. And we'll go through next week some examples of how we calculate person times, and especially how we look at this particular figure. So you're going to see this figure on your exercise. You're also going to see this figure on your homework. And I will tell you now, you are also going to see this exact same figure on your exam. So we are going to go through this in class next week. There's a recorded lecture that goes through this exact same figure, and what changes, these arrows and these lines change. So you'll come up with a different answer every time you do it. But I can 1000% guarantee you, this is on your homework, you already have that. This is going to pop up on the exam, so you need to be comfortable using this figure to calculate an incidence rate, to calculate a prevalence, and to calculate person time. There's the recorded lecture for that you can watch before next live session. And next live session, we will spend about 20 to 30 minutes specifically going all over incidence and prevalence, and then having you all do some calculations on your own. That part B of the exercise. And if we have time, we'll go through part C, but you should be able to do that without additional help. If you have questions, let me know. And then we'll also next week, I said in the email, I switched around the schedule because in your syllabus quizzes, you all had a lot more curiosity about kind of infectious disease epidemiology and COVID-19 and spread of disease. So next week, we're actually going to talk about, our recorded lectures talk specifically about infectious disease epidemiology. And so then after we talk specifically about incidence and prevalence and the calculations in the beginning, we'll have about a 45-minute to an hour conversation specifically about infectious disease epidemiology and COVID-19, vaccination rollout, and some of those other things. And if there are specific things you'd like me to cover about that, I have some of them in the syllabus quiz I'm going through, but if there are other things that you'd like me to cover, I'm happy to do so. If it's within my wheelhouse, there are many things that, even though I'm an infectious disease epidemiologist, there are many things that we are all trained in different ways that I may not be able to cover. So if I can't cover it, I'll either point you to the right resources or make sure I get that information for you. And one thing I want you to think about before next week is how our vaccination rollout has gone, who has gotten vaccinated, how do we see kind of that vaccination distribution? Is it equitable, or do we see that happening equally across race, ethnicity? Do we see, when we think about who essential workers are, do you all think that the right people are currently being vaccinated? Why or why not? And I kind of want to have a little bit of a discussion surrounding that as it relates to COVID-19 and vaccination rollout in general and what we've seen. So think of that. And even, if you want to look up some articles on your own, there's lots of articles around the vaccine rollout. That might be helpful, but I won't point, you're not required to, and I didn't post any online. So before we end, what questions do you have? And we went a little over 11 today, so I apologize, but I wanted to make sure I wanted to get at least that part A of the exercise. So what questions do you all have? We all good? Feeling okay about the calculations? They're not too much, hopefully. I realize there's a lot of formulas. You're going to use them a lot, but don't ever focus on memorizing the formulas. You're never going to have to do that. You'll always be able to Google them even after this class if you come across them. So I try to de-emphasize the things that you can do a quick 2-minute Google search on, and emphasize how do we actually use these and what they mean when we do the calculations. So, all right, well, if I'm seeing no questions, thank you all for joining me today. I will see you all next week. As I said, if you haven't done a student hour with me, which I believe, at least looking at the names here, I believe I've met with pretty much every single one of you that's here in the live session. But if you have any questions, never hesitate to reach out via email, via text, via Zoom for the student hours. I'm always happy to help. Start working on your homework early. And if you have questions on it as well, let me know, or work in groups. I do highly encourage you all to work in groups with each other. So if you have, even if you don't know anyone in the class, because maybe you're a transfer and you haven't met anybody in person, share contact information when we do breakout groups, or go on or find other students in the class. I could even set up something for you all if you would want, so that you can work together. That still means doing your work individually, but for a lot of these things, having someone you can talk about the problems with and you can work through things together is extremely helpful. And that us being virtual kind of limits those groups that you can form in the classroom. So if you'd like me to connect you with other students in the class, if you all just email me, and I have multiple people email me, I can kind of send out a blast and say, here's the students who'd like to be connected to just those, and you can all work together. And Mike just share this. Yeah, you could do a group meet, you could do a Snapchat, you could do a Discord. I don't really care how you all get together, but I encourage you all to work together, except for on the exams. They are always individual. So, all right. Well, thank you all. Have a great rest of your week and weekend. I'll send my updates as always. I'll leave this open for a few minutes. If anyone has any questions as we end up, feel free to unmute yourself and ask them, and we can go from there.
Thank you.
Thank you all.
Thanks, Professor.
Thank you, Professor. Have a great week.
Thanks, you too.
And I was just gonna let you know, that paperwork that we were talking about, with the resource center and everything.
Yeah.
They just sent that to me from Palomar finally. So now I just have to send it over to Cal State, and then I should be good. And then I think I'll be able to give you the accommodations from that point.
Perfect. Sounds good. I'm glad that all worked out, and that was quick too. So I'm super glad that all happened.
I'm glad.
So.
Yeah, it wasn't too long. So
Cool.
yeah, thank you very much for today, and I hope you have an awesome rest of your day.
Thank you. You too, Trent. I'll talk to you later.
Yeah.